What is the approach to a patient presenting with chronic obstructive pulmonary disease? Consider a case of a 45-year-old man who visits his primary care physician complaining of productive cough persisting for at least 2 years. He has also experienced exertional dyspnea over the last 3 months. He has a history of smoking about 60 cigarettes daily for the past 30 years. Given the patient's presentation of chronic lung symptoms and the presence of risk factors, particularly a substantial pack-year smoking history, chronic obstructive pulmonary disease should be considered as part of the differential diagnosis. What is COPD? COPD is a progressive respiratory disorder associated with chronic pulmonary symptoms. Patients may present with dyspnea, chronic cough, or sputum production, and evidence of airflow limitation or obstruction that is not fully reversible. It is a preventable and a treatable pulmonary disease. COPD is a chronic inflammatory condition and is associated with an abnormal inflammatory response of the pulmonary system to noxious particles. Irritants such as cigarettes activate both macrophages in the alveoli, which then release neutrophil chemotactic factors such as IL-8 and LTB4 for leukotriene B4. Macrophages and neutrophils releases proteases, which destroys the lung parenchyma. Antiproteases such as alpha-1 antitrypsin inactivate these proteases, which can be low in patients with COPD. Both irritants such as cigarettes and inflammatory cells then lead to lung tissue destruction that results in fibrosis of the small airways and reduced elastic recoil, and this causes static hyperinflation. As the inflammation worsens, the airflow obstruction increases. As a result, patient inhales earlier before exhalation is completed. This causes air trapping. Do you know the chest X-ray finding for air trapping? What is most likely tested on your exams includes chest X-ray findings that has a widened AP diameter and a flattening of the diaphragm. What is the most important risk factor for COPD? It is exposure to cigarette smoking. Besides smoking, what are the other irritants related to COPD? Irritants include occupational dust and chemicals, as well as indoor and outdoor air pollution. What is a genetic condition that is associated with COPD? It's alpha-1 antitrypsin. A 45-year-old man presents with his wife for a routine checkup. He has a 30 history of smoking 20 cigarettes daily, denies experiencing shortness of breath and chronic cough, asserting that he is in good health and has no intention of quitting smoking. His wife inquires about the possibility of him having COPD. Should you screen him for COPD? If the patient is asymptomatic, COPD screening is not recommended, even if the patient has a significant history of smoking. If the patient is at least 40 years old with history of chronic cough, which is a cough of at least 3 months, as well as progressive dyspnea, chronic sputum production with risk factors stated previously, then you should consider COPD screening. What is the diagnostic testing for COPD? Spirometry is ordered to assess airflow obstruction. But please keep in mind that spirometry is not the same as pulmonary function test, since pulmonary function test contains three key components, and these tests includes lung volumes, spirometry, and diffusing capacity, also called DLCO. Spirometry is used to assess for an obstructive lung pattern and is helpful in diagnosing COPD. COPD is confirmed by the post-bronchodilator FEV1 FVC ratio of below 70% or 0.70. Obtaining DLCO and lung volumes is not necessary to diagnose COPD, and therefore it's not necessary to order a pulmonary function test. FEV1 is the total amount of air that can be forcibly exhaled in 1 second. FVC is the total amount of air that can be forcibly exhaled after a maximum inhalation. FEV1 and FVC is the percentage of the total exhaled volume that can be done in 1 second. The ratio is from the volume of air exhaled in the first second, otherwise called as forced expiratory volume in 1 second, FEV1, and this is divided by the total volume of air forcibly exhaled from the point of maximal inspiration, known as forced vital capacity, or FVC. The airway obstruction, if fixed, means that the airway obstruction is present even following bronchodilators. Once a COPD diagnosis is confirmed by a post-bronchodilator FEV1 over FVC ratio of less than 0.7 or 70%, assessment of airflow obstruction is identified by looking at the FEV1 percentage. The GOLD guideline uses FEV1% predicted, as shown in the picture, to identify the severity of airflow obstruction in COPD. The patient may have a mild airflow obstruction, characterized as an FEV1 of more than 80%, to a very severe lung obstruction, characterized as an FEV1 of less than 30% of predicted. Here is a 45-year-old male with COPD. A pulmonary function test 2 years ago showed an FEV1 of 60%, FEV1 over FVC of 65%, and a DLCO of 80%. At that time, he was started on tiotropium, which is a long-acting anticholinergic inhaler, and albuterol rescue inhaler. He has not had any hospitalizations for the past year, but reports an increasing cough and exertional dyspnea over the past 3 months. Vital signs includes a blood pressure of 120 over 70, a heart rate of 70, a respiratory rate of 14, and a resting oxygen saturation of 94%. What is the first assessment to consider? First, find out if the patient is compliant with his inhaler and make sure that the patient demonstrates appropriate inhaler technique. Once both medication compliance and inhaler techniques have been confirmed, the next best step in a patient with reduced exercise intolerance and has COPD is to order a repeat spirometry. Spirometry is ordered in patients with established COPD who reports a change in their symptoms. 2 years ago, his FEV1 was 60%, which places him under GOLD 2, or moderate airflow obstruction, if you refer back to the previous slide. The 3 common types of COPD that are tested includes emphysema, chronic bronchitis, and ACOS, which is asthma and COPD overlap syndrome. Emphysema is due to destruction and enlargement of the alveolar spaces. On physical exam, patients may have decreased breath sounds. On imaging, such as chest x-ray, there is evidence of hyperinflation of the lungs. Chronic bronchitis is associated with airway inflammation, leading to sputum production. Clinically, it is defined as chronic productive cough for 3 months for 2 consecutive years. The last one is asthma and COPD overlap syndrome. Pink puffer is an old term that is now recognized as severe emphysema. It is a generalized term for a person who is thin, breathing fast, and is pink. Blue bloater is an old term that is now recognized as severe chronic bronchitis. It is a generalized term referring to a person who is overweight and bluish colored skin related to cyanosis, mostly around the lips and fingertips. Once COPD is confirmed, what is the next best step? It is important to assess the severity of the patient's COPD, degree of airflow obstruction, the number of acute exacerbations in the last year, and any comorbid conditions. Symptoms of COPD include dyspnea with exertion, or at rest, plus chronic cough, often with sputum. Chronic cough is defined as cough of at least 3 months versus acute cough, which is a cough of less than 1 month. One of the validated tools to assess a patient's breathlessness is called COPD Assessment Test, or CAT. It is a comprehensive 8-question graded questionnaire. It is quick and easy for patients to complete. It provides a score of 0 to 40 to indicate the effect of COPD in a patient's day-to-day activities. The second common validated tool to assess a patient's breathlessness is called a Modified Medical Research Council Dyspnea Score, also called MMRC scale. The MMRC score goes from a scale of 0 to 4. This is a subjective questionnaire that you ask the patient during the visit, or you can ask them to fill this out before their visit. A scale of 0 is a patient with no breathlessness except with strenuous exercise. A scale of 4 is a patient who is too breathless to leave the house or breathless when dressing or undressing. What is included in the workup once COPD is established? CBC with differentials to look for eosinophils is very important. A patient with higher eosinophils may have an inflammatory phenotype. In this situation, inhaled steroids can directly treat this condition and reduce COPD exacerbations. Alpha-1 antitrypsin level is indicated in a patient presenting with symptoms related to COPD and who are younger than 45 years of age or have a family history of COPD. COPD management includes smoking cessation, pulmonary rehabilitation, and maintenance medications. Once a patient quits smoking cigarettes, it can slow down the decline in airflow obstruction. Smoking cessation is always the correct answer on your exams. Nicotine replacement, Chantix, Zyban, and cognitive behavioral therapy are good options. What are the bronchodilator therapy that are given in patients with COPD? They are beta-2 agonists, anti-muscarinic inhalers, methylxanthines, and LABA plus LAMA combinations. These inhalers are available as short-acting and long-acting inhalers. Beta agonists end with OL, such as salmeterol and formoterol. Short-acting beta agonists includes albuterol and levobuterol. Long-acting are commonly combined with inhaled corticosteroids. So be careful if the patient does not require the steroid portion. Combination therapy includes Advair and Symbicort. Muscarinic antagonists end with IUM, such as tiotropium. Methylxanthines include theophylline. Theophylline is no longer recommended. It's no longer recommended due to its associated toxicity and reduced efficacy. Unlike asthma, in COPD, steroid therapy is not the standard of care. Inhaled steroids are not given as monotherapy in patients with COPD. Do you know the two most common adverse effects of inhaled steroids? The two most common adverse effects that are commonly tested on your exam includes recurrent pneumonia and bruising. Inhaled steroids end with ONE, such as fluticasone. As far as systemic glucocorticoids, it is recommended only for short duration of treatment and mostly for acute COPD exacerbations. Long-term use of systemic steroids, such as prednisone, is not recommended for maintenance therapy for patients with stable COPD due to lack of demonstrated benefit and its common side effects, such as muscle weakness, hypertension, and diabetes. Now that we have confirmed a patient of having COPD based on post-bronchodilator FEV1 over FVC ratio of less than 0.7 or 70%, and also established the patient's airflow obstruction based on FEV1 percent predicted, the two important questions to know next is the number of exacerbation in the past year and the patient's current symptoms. Symptoms should be assessed using an MMRC dyspnea scale or CAP, as seen on the x-axis. The y-axis is the exacerbation risk based on the patient's history of exacerbations in the past 1 year. When deciding on which inhaler to prescribe to a patient, it is important to identify if the patient belongs in group A, B, or E as shown on the right-hand side. Group A includes patients with COPD who are less symptomatic. This includes an MMRC grade of less than 2 or a CAT score of less than 10, and at low risk of exacerbations, typically 0 to 1 exacerbation per year without hospitalization. The recommendation includes a long-acting bronchodilator plus short-acting bronchodilators as needed. Group B includes patients with more severe symptoms. This includes an MMRC grade of more than 2 or a CAT score of more than 10, and a low-risk exacerbation risk of 0 to 1 exacerbation per year that did not require a hospitalization. The recommendation includes a dual long-acting bronchodilator therapy, a fixed dose combination of LAMA plus LABA. Group E includes patients with high exacerbation risk, at least 2 COPD exacerbations in the past 1 year, or at least 1 COPD exacerbation leading to hospitalization in the past 1 year, regardless of symptoms. The recommendation is a dual long-acting bronchodilator therapy of LAMA plus LABA plus or minus inhaled steroids. If the patient has peripheral eosinophils of at least 300, inhaled steroids is added to the LABA plus LAMA fixed combination. Here is a 45-year-old male patient with chronic cough and exertional dyspnea. He smokes cigarettes and has a 20-pack-year smoking history. His spirometry shows an FEV1 of 70% of predicted and a post-bronchodilator FEV1 over FVC ratio of 60%. His MMRC is 2. For the past year, he denies hospitalization for COPD, but he was treated 4 months ago for a moderate COPD exacerbation at the clinic. What is the most appropriate next step? First, encourage the patient to stop smoking. In addition to counseling, what is the most appropriate treatment? Short-acting as needed, plus LAMA or LABA with pulmonary rehabilitation. Here is a 45-year-old male with COPD and was started on LABA plus ICS combination 2 years ago. He demonstrated appropriate inhaler technique, stopped smoking, and is compliant with his medication. He has not had any exacerbations for the last year, but now reports easy bruising. What is the next best step in management? Discontinue LABA and inhaled steroids, since inhaled corticosteroids may be the cause of the patient's complaint of easy bruising, and choose either a LABA or a LAMA or a LABA plus LAMA combination instead. The GOLD guideline recommends considering de-escalating from an inhaled steroids if the patient also develops pneumonia. If the inhaled steroid does not reduce COPD exacerbations, or if there's no clear indication for inhaled steroids in the first place. Roflumilast is a selective phosphodiesterase 4 inhibitor. It is an appropriate add-on therapy in severe COPD with a history of recurrent exacerbations despite maintenance therapies. It has been shown to improve lung function and reduce risk and frequency of COPD exacerbations. The brand name is Daliresp, and the most common side effects that are seen on your exams include weight loss and decreased in appetite. What antibiotic has been found to decrease a patient's COPD exacerbation? The antibiotics are macrolides. Macrolide antibiotics have inflammatory effects as well as antimicrobial effects. When added to the usual COPD regimen, azithromycin can be given to reduce the number of COPD exacerbations and even improve quality of life. The primary concerns with long-term macrolide therapy includes antibiotic resistance, hearing loss, and QTc prolongation. A 45-year-old male patient with COPD has a 20-pack-year smoking history, but quit 5 years ago. He currently takes budesonide plus formoterol and tiotropium and albuterol as needed. So he is on a inhaled steroid, a beta-2 agonist, and a LAMA and a SABA as needed. 2 weeks ago, he was hospitalized for acute COPD exacerbation. Which of the following is the most appropriate add-on to reduce his COPD exacerbation? You can either add roflumilast or add azithromycin. Routine immunizations are also recommended since infections are the most common cause of acute COPD exacerbations, and the immunization includes annual influenza, pneumonia vaccine, annual COVID-19 vaccination, and Tdap. Pulmonary rehabilitation is a non-pharmacologic therapy that is known to relieve symptoms, reduce hospital admissions, and even improve quality of life. Pulmonary rehabilitation is always the correct answer on your exam. Long-term oxygen therapy is an option that has been found to decrease morbidity and mortality in severe COPD, as well as improve quality of life. However, there are strict criteria for starting home oxygen. If the patient has resting hypoxemia, defined as a pulse oximetry of less than 88%, or if the patient has a resting PaO2 of less than 55, which is found in an ABG. Here is a case of a 45-year-old patient who is admitted to the hospital for COPD exacerbation. His blood pressure is 100/60, respiratory rate of 30, and heart rate of 120. On exam, he is anxious and using his accessory muscles of respiration. ABG shows a low pH of 7.2 and a high PaCO2 of 70. What is a non-pharmacologic therapy that is known to improve symptoms, reduce intubation rates, and even reduce mortality in severe acute exacerbations of COPD? The right answer is non-invasive bilevel positive airway pressure. In patients with severe COPD and has upper lobe emphysema who underwent pulmonary rehabilitation with minimal improvement, a lung volume reduction surgery results improved survival compared with medical treatment. Another option for surgical therapy is lung transplant, and the referral for a lung transplant is considered if the Bode index is more than 5, which we will discuss later on, or an FEV1 of less than 25% of predicted, a DLCO of less than 25% of predicted, resting hypoxemia, hypercapnia, secondary pulmonary hypertension, accelerated decline in FEV1 shown on the spirometry. What is a known prognostic indicator for COPD? It is called Bode index. B is body mass index, O, obstruction of airflow, D is dyspnea, and E is exercise capacity. It is a score that gives an estimate of a patient's 4-year survival. Bode is used for a few months after discharge from a COPD exacerbation to assess a patient's prognosis. Lung cancer screening includes yearly low-dose chest CT for patients 50 to 80 years old with a 20-pack-year smoking history who is currently smoking or quit in the last 15 years. Now that we talked about our approach for COPD evaluation and management, let's do some rapid-fire questions. Which genetic condition is associated with COPD? Alpha-1 antitrypsin. What are the two common chest X-ray findings related to air trapping? Widened AP diameter and flattening of the diaphragm. Can we screen patients who smoke for COPD even if they're asymptomatic? The answer is no. What are the three components of a pulmonary function test? The three components include lung volumes, spirometry, and diffusing capacity. COPD diagnosis is confirmed by a post-bronchodilator FEV1 over FVC ratio of less than 0.7 or 70%. This validated tool is a comprehensive 8-question graded questionnaire. The validated tool is COPD Assessment Test, also known as CAT. What is the MMRC score if the patient is too breathless to leave the house, or breathless even when dressing or undressing? The MMRC score is 4. True or false? Maintenance therapy for stable COPD typically involves the use of oral prednisone. The answer is false. What is the initial therapy for Group A? The initial therapy for patient in Group A includes a LABA or LAMA plus short-acting bronchodilator as needed. What is the initial therapy for Group E with peripheral eosinophil of 100? The answer is LABA plus LAMA without inhaled corticosteroids. What is the initial therapy for Group E with peripheral eosinophil of 350? The initial therapy in a patient in Group E includes LABA plus LAMA plus inhaled corticosteroids. This selective PDE4 inhibitor is an add-on therapy in severe COPD with a history of recurrent exacerbations. The answer is roflumilast. This antibiotic is an add-on therapy in severe COPD with a history of recurrent exacerbations. The answer is azithromycin. True or false? Home oxygen is recommended if the oxygen saturation is less than 90%. The answer is false. Resting oxygen saturation should be less than 88%. If the patient has at least 20 pack-year smoking history and agrees to lung cancer screening, which is true, order low-dose chest CT times 1, order annual low-dose chest CT, order low-dose chest CT every 5 years, or order a chest X-ray. The answer is annual low-dose chest CT. Thank you for tuning in. If you find this valuable, please check out our Instagram page or visit our YouTube channel for more high-yield content that can assist you in preparing for your internal medicine shelf exam and studying for your USMLE. We provide short-form videos that cover essential concepts and offer guidance on approaching clinical questions. Keep in mind that the USMLE Step 2 CK test comprises of about 50 to 60% internal medicine-related questions. Scoring well on the USMLE Step 2 is crucial when applying for residency programs since USMLE Step 1 is now a pass or fail. Thank you and take care.